Hello, everyone. It's a good pleasure to be here with you. Do you listen to me? Okay, Sam?
Yes, it's okay. Just to make it bigger.
Great, Sammy. Thank you for the invitation, Dr. Tom Bennett, and great to see Dr. Salim here, and great presentation of Dr. Ken. So I'm going to talk a little bit with you about the management of penetrating lesions of skull base by bladed weapons. I'm from Brazil, University of São Paulo and Federal University of Amazonas. I don't have any disclosures. This is our hospital, as you can see, and in the middle of the Amazon forest. Here is the Black River, as a large river here, one of the most largest river in the planet, and in the middle of the Amazon. Okay. This is Manaus, the capital of Amazonas, and it's the only city that we have CT scans on all over the state. The state is very huge. As you can see, it's the largest state in Brazil. Here, Manaus, Amazonas, Brazil. It's the largest state here. And just to remind that that injury is a very it's a terrible problem in high and especially in low and middle income outcomes countries, as you can see. If you talk about the scale of this problem, we can see that road traffics are a burden of patients sustaining this injury, and particularly interpersonal violence. But when it comes to Brazil, interpersonal violence, it's very, very huge, the scale of people being harmed. So what we are going to talk about is TBI caused by penetrating injuries that almost all the cases are caused by interpersonal violence. Just a difference between closed versus penetrating head injuries. Here, an example of a closed head injury of a patient sustaining subdural hematoma, and this patient with a linear skull fracture. The classification, when it comes to penetrating TBI, we can have patients sustaining mesial penetrating TBI or non-mesial penetrating TBI. The difference is basically because of the kinetic energy that is it's higher in patients sustaining mesial TBI, that we have the velocity of the projectile more than 100 meters per second, in contrast to patients sustaining non-mesial TBI that's caused by bladed weapons, for example, or wood, iron, nail guns, and plastic objects. If you see the guidelines in terms of traumatic brain injury, you have lots of guidelines, but most of these guidelines are developed in patients sustaining closed TBI. And what the evidence about penetrating brain injuries, we just have this paper published in Journal Trauma in 2001, showing some pitfalls and how to manage these patients with penetrating brain injuries. And most of the data is related to mesial TBI, so caused by gunshot, military or civilian. But there is no data about non-mesial TBI. That is a huge problem in low and middle income countries, as Brazil. We have these patients, this paper showing the prediction of outcome, patients sustaining penetrating TBI. Most of these patients were in mesial TBI, and just some patients in this cohort was sustained non-mesial penetrating TBI. So in conclusion, The evidence for penetrating brain injuries are scarce, and evidence for non-missile penetrating TBI is even more scarce. And although uncommon lesions, they are pretty challenging, as I'm going to show you some cases of non-missile TBI. And why this is a challenging patient, most of the lesions that occurs, the region is the orbital region, as we all know, because the bone is more fragile, and the region of the frontal sinus, and also the temporal bone here. That's the sites of injury when it comes to penetrating non-missile penetrating TBIs. What we have to do when we have a patient sustaining this kind of lesion, a clinical history is important, as the physical exam, ATLS, and in general, it's important to see this, that most patients are not in coma. So those patients have penetrating a non-missile penetrating TBI, and these patients are not in coma. Most of the patients are talking and walking without no more alterations in the physical exam. But we need to expect mainly to look for opened wounds, sutured wounds, any evidence of CSF leakage, facial symmetry, periorbital retroauricular bursts, extraocular movements, and if this patient has any kind of motor deficits. The next step, of course, is the CT scan. With the CT scan, we can see different types of lesions, but in these penetrating lesions, we can find, besides of skull fractures, we can find pneumocranial, pneumocephalus, suggesting CSF leakage. As you can see, we can reconstruct this. This is important for you to decide what is your planning of what approach you are going to perform. The next step, generally when I have these lesions committing the skull base, we need to perform a CT angiogram. This is very important for you to see the vessels of the skull base, that they can be compromised. As this, we can make a venous angiogram. And this is an example of the importance of performing CT angiogram. This is a patient that, although it's not a penetrating TBI, is a patient with an open TBI with a huge frontal skull fracture with this epidural hematoma, also with several fractures in the skull base, here in the ethmoidal bone, and the roof, the lateral wall of the orbit, and also here in the roof of the orbit, and also around the sila. This patient went to the operating room. This patient did not perform any kind of angiogram, CT angiogram, and the surgeon was taking off the bone on the skull base, and there was a massive hemorrhage due to laceration to the carotid artery. And this happened because there was a fracture around the artery. And as you can see here, the sila was also fractured about due to this injury. So this is the CT scan, and this patient was sent to the angio to perform an angiogram to block the carotid artery, and this is the final CT scan that unfortunately was this patient did not evolve with a good outcome and did not survive. So this is important for you to know the importance of performing CT angiograms in this kind of patients. The time of surgery, As we consider that this is an open fracture, earlier you perform the surgery better for the patient to prevent infections. Actually, we did a retrospective study comparing those patients operated before 24 hours and later than 24 hours, and we did not find any difference in terms of outcome. However, we need to pay attention because this was not controlled for important variables. So it was not performed the multivariate analysis for us to attest this as to state this, that this is the best management for these patients. Personally, I continue to operate earlier as possible these patients. This is a patient that came to our emergency department with a GCS of 15, just with right hemiparalysis. There was a lesion sutured around the nose. There was no handle, knife handle. This patient went to evaluate the cervical spine, and the X-ray showed this blade here. This patient went to perform a CT angiogram. That fortunately, there was no arterial lesion. This was in no case. That's why the image is not so good. This is the MRI showing where the blade passed through between the basilar artery and the carotid artery. And this patient went to the operating room, and it was possible to remove the knife. And another CT angiogram showed no arterial lesion, fortunately. This was another patient, it's a screwdriver through the temporal bone. The screwdriver reached the carotid canal. This patient had a subdural hematoma. So what we did went to leave the patient in the operating room, performed a large craniotomy, and we evacuated the hematoma, approached the carotid artery through the Sylvian fissure, and we took out the screwdriver under direct visualization of the carotid. Fortunately, there was also no lesion, and this patient evolved pretty well. This is the following angiogram. So we need to be careful. It's very important not to remove any penetrating object from the school in the emergency department until both trauma and neurosurgical evaluation are obtained. And the protruding object should be stabilized, and provision should be made to protect it from movements during transportation of the patient to prevent further injury. This is another couple of cases. This is a boy, the 10-year-old boy playing with kids in the park that was wounded in the left orbit. He was very good neurologically, DCS 15. He just had a punctated skin lesion, a periorbital edema. He went to a secondary hospital, sutured and discharged home. A few later, he came to us with a history of fever. We performed a CT scan, and we had this hypodensity in the frontal lobe and a fracture in the roof of the orbit. We operated this patient, and there was a bamboo stick that was there, and there was no signs externally of bamboo stick. So we need to pay attention to the external exam of the patient with these suspicions. Here is another child that she had a GCS of 15 when he arrived to our department, and just with this sutured lesion, there was a suspicion of TBI. Then she went to the CT scan. We found this this hypodensity, linear hypodensity in the temporal region. Actually, it was a wood stick, a very large wood stick. So we need to pay attention that if suspected, if ideally an MRI may be obtained if wood is suspected, but actually sometimes we just have a linear hypodensity leading us to suspect that this is wood. Other cause of non-penetrating, non-missile penetrating TBIs is harpoon. Here in Manaus, we have lots of patients sustaining this kind of lesions, unfortunately. And the big champion here is the machete, this large, this big knife here. And what is interesting is because the lesions, the primary region of this kind of lesion is the frontal and parietal bone. What is unusual when it comes to non-missile penetrating TBI. These lesions are typical. Generally, we don't have so much alterations in the brain, this subarachnoid hemorrhage, but actually this kind of lesion is very, we need to be careful because of the presence of hair and dust that we can find. So we need to operate this patient earlier to prevent infection. We have a cohort of 80 patients currently, and most of patients are male. And the most cause of non-penetrate non-missile TBI is machete, with almost 50% of the patients. It's interesting that the independent predictor of unfavorable outcome in these patients are neurological deficit, because the lesion is over the frontal and parietal bone most of times. And finally, take-home message: non-missile TBI are very rare. Orbital and temporal regions are the main region of this kind of lesions. Vascular evaluation is crucial, and multidisciplinary management may be necessary in some cases. Also, injuries without vascular lesions have good prognosis. So I want to invite you in 2025 to our Academy Brazilian Congress of Neurosurgery that we held here in Manaus. Thank you so much for your audience.
Thanks a lot, Professor Robson, for this excellent presentation. Is there any question from panelists?
I just wanted to make a comment. That was a beautiful presentation, an interesting one, Professor Robson. In the US, we see a lot of gunshot wounds to the head in inner cities, not as much penetrating injury, but you have such an amazing, it just shows the differences in the, in the cultural thing. So it was very educational for us to see your experience.
Thank you for your comments. Yeah, that's we have a lot of patients. When I come to Manaus, my neurosurgery practice was in São Paulo. That's the large city in Brazil. We don't have this kind of lesions. When I came to Manaus, right. A lot of samurai guys here.
Yes, very interesting. Very, very interesting. Thank you so much for that.
Oh, you're welcome.